Hello, my name is Ken Swenerton. I'm a medical oncologist of the BC Cancer Agency and a clinical professor at the University of British Columbia. I've spent most of my career aiming to care for women with ovarian cancers. It's been a most rewarding and frustrating 3 decades. Although but 1 woman in 70 in Canada will develop ovarian cancer, this group of diseases has major public health and social impacts. Diagnosed most frequently during the busy years of midlife, it profoundly affects the individual, her relationships, and career. The goal of cure can be and is realized, but for 2 of every 3 is elusive. This adds up to some distressing statistics. The potential years of life lost because of ovarian cancers are almost 1/3 of those lost to breast cancer, although breast cancer is diagnosed 8 times more frequently. The loss of life years from ovarian cancers is greater than for all other gynecologic cancers combined. The costs are enormous. No effective screening tests are yet available that would permit early diagnosis and better outcomes. In fact, as the graph shows, the proportion of those who survive for 1, 3, and 5 years after diagnosis have improved only marginally since 1980. Although during this interval many improvements have been introduced, the era has been characterized by a one-treatment-suits-all approach. Have we ignored exploitable differences amongst ovarian cancers that could improve matters? Perhaps we have. Ovarian cancers tend to present in one of 2 ways, suggesting the existence of important biological differences. Less frequently, disease grows locally within the pelvis, producing progressive bladder and rectal pressure symptoms. The patient will become aware of an enlarging mass. These cancers often are found to be of non-serous type, either clear cell, endometrioid, or mucinous, cancers with an often more favorable prognosis. However, more often, disease appears to involve serosal and peritoneal surfaces throughout the pelvis and abdomen, with ascites. This pattern predicts a pathological diagnosis of high-grade serous cancer and a poorer ultimate prognosis. This is the disease seen to develop in those with an inherited predisposition to breast and ovarian cancers. At least 20% of serous cancers are related to BRCA gene mutations. These serous tumors of high grade are the most frequently seen. Most respond well to initial treatment with chemotherapy, but cure is infrequent. This makes imperative efforts to identify effective preventative tactics.